acquired vertical pendular nystagmus, the role of peripheral vestibular system. I would like to thank the other three remaining authors, Jack Manyan, Srinivas sir, and Vijendra sir. So the clinical details about this patient is 23-year-old male, got operated thrice for the right ear otitis media with cholesteatoma and also vertigo. Initially the surgeries were done thinking that some semicircular canal fistula. But there was no fistula, but even after surgery, the vertigo persisted. The vertigo, now the patient presented with vertigo with ear fullness, tinnitus, and of course hard of hearing. So for the last 2 years, he has developed severe postural imbalance, even in between the rotatory vertigo episodes. That's the most important thing. And on examination of the patient had a 4-arc oscillation like this of the whole body in the pitch plane. That increases in amplitude with eye closure. So as morning Kshitij has told that this is the pitch plane. So that's the thing. And examination of the eyes reveal a vertical pendular nystagmus that increases with the removal of fixation. HRCT mastoid shows no fistula and MRI brain is normal. VNG shows a hypoactive right labyrinth and also the same result with the calori. So just I would like to show the pendular nystagmus here. Just see the pendular nystagmus there. The nystagmus plane in the two eyes is conjugate, the waveform is sinusoidal as you see, and the time synchronous in two eyes. The body oscillation, one important feature is the body oscillation and the nystagmus are of the same frequency around 0.5 Hz. The amplitude of the nystagmus is 10 degrees in the vertical plane. So this is the video of the patient. He was even unable to stand. See the 4-arc oscillation. So we decided so this is the MRI and CT. Everything was normal, so that's why I could not keep the close pics there. So then I did a vestibular neurotomy, right vestibular neurotomy. And for his incapacitating vertigo, peripheral vestibular symptoms, and no other obvious cause. That's why I did a vestibular neurotomy. That is the justification what I give for my vestibular neurotomy. Surprisingly and honestly, we did not expect the improvement of the 4-arc oscillation before surgery. This is a retrograde analysis. We did the surgery for Meniere's disease to improve the vertigo. That's the thing. But for our surprise, the vertigo disappeared completely. That's expected. But the main thing is the 4-arc oscillation has gone. He showed a dramatic improvement in body oscillation and vertical pendular nystagmus 2 months after surgery. I'll show you the video. The nystagmus, the body oscillation, everything has been disappeared completely. And now he can walk and run independently. And this video, so first thing is this is after 2 months at Srinivas sir's clinic. It is in Bangalore. 2 months after vestibular neurotomy, the patient was like this. So just to give a small idea, usually pendular nystagmus, central, either midbrain or pons. Just I don't want to go into details of all these things, the time is lagging. And now there is something called oscillator concept. This we need to know. Because even I don't know. The extensive research on this was done by Srinivas sir, and it is his brainchild, honestly. Patient was Vijendra sir's patient. Surgery was done by me, guided by Professor Manyan, and this concept is Srinivas sir. The main important concept is even today morning, if somebody has attended a lecture by Srinivas sir at 8 o'clock, he said that any neurotransmitter will induce a secondary messenger within the neuron, which does multiple functions. Apart from exciting the nerve, it also influences the nucleus or something like that for adaptations. That's why he said migraine can be induced after 48 hours or after 72 hours. while you take a trigger today, the migraine can come after 3 days. That's the thing. So the oscillator concept is the cerebellum can influence the eye and the body movement. So in our patient, there is a synchronous oscillations of the eye and body, as I have mentioned, 0.5 Hz. This requires the cerebellum to produce a synchronous output to bring about the movement involving different regions of the body. And this requires an oscillator. We propose this oscillator to be the inferior olivary nucleus. Inferior olivary nucleus through the climbing fibers to the cerebellum. So this is the proposed concept, almost all similar to the famous Guillain-Mollaret triangle. So Guillain-Mollaret triangle is proposed for the ocular myoclonus. And now we propose an equivalent to the vestibular equivalent to the Guillain-Mollaret triangle. That's where we propose that vestibular nuclei and the inferior olivary nuclei, due to this oscillatory concept, continuously influence the cerebellar nuclei, thereby causing the nystagmus as well as the body oscillation. This was the new concept in, hopefully in ENT. This is somewhere lying in the neurology books. He has gone to so much depth that he has applied this thing to ENT. Probably the first case, sir? Probably the first case like this, or? Yeah, yeah. So the last slide, we propose the continued presence of severely unstable peripheral vestibular lesion could have impaired the output of the vestibular nucleus to the inferior olivary nucleus. It is likely that the peripheral vestibular offending output, subserving the pitch plane, has become maladapted in this patient, leading to the corresponding change downstream in the olive and the cerebellum. Significantly, this patient showed dramatic improvement of the symptoms following vestibular neurotomy. Thank you. And one more thing, even in the vestibular olivary cerebellar connections are mapped in the planes of movement. All the things are mapped.